Hello, today we're going to talk about the summary from the January EMS training. We covered a wide variety of topics, so we'll talk about all those briefly. One of the main things that we looked at was end-tidal CO2 monitoring. We looked at a PowerPoint, which Sean is going to share with you. I'll also attach an article that has sort of the best summary of the details of using that. I think the biggest takeaways are that I use it as a binary thing to look for apnea. So if a patient took a lot of something and they're down from their benzos or their alcohol or their opioids, whatever that is, and they're down, and you want to watch their respirations, that's a good tool to know if they're breathing or not. It's also a very good tool when we give patients something that can impair their breathing. Obviously, the opioids are probably the most predictable in terms of decreasing respiratory drive, then probably the benzos, if you're looking big picture wise, and then your other stuff like Zyprexa and Druperidol. Ketamine obviously can. It doesn't typically, but it can. And so you need to be cognizant when you give any of those medications that potentially it can affect respiratory drive. And again, you don't know what the patient took prior to you giving them medication. So it may be a trauma patient, but maybe it's a NVC trauma patient who just is driving home from the bar drunk. So they have a lot of alcohol on board, and now you're giving a pain medicine, right? So that combination is not very predictable. So whenever you give those medications, be cognizant that you can impair respiratory drive. So I think that's the best use of that. The actual number, I'm not as concerned about. When I monitor patients in the ER for the same thing, like if I'm monitoring an opioid overdose that got Narcan and looks like they might need some more Narcan, it's really just, are they breathing or not? When we do sedations in the ER, it's the same thing. We're really looking at if they're breathing or not. The number is not so concerning to me. So, but the number, when they go apneic with the end-tidal CO2, you will pick up that much sooner than somebody who becomes hypoxic. Right, so when we do a sedation in the ER, we have a face mask, oxygen on them to pre-oxygenate them because we have all the time in the world to do the sedation, but we're also prepping if something would go bad with the airway that we want lots of time, right? So they're on oxygen to wash out all the nitrogen. So they hopefully don't get hypoxic. That's the whole goal. When we watch with end-tidal CO2, we will pick up that they stop breathing so we can do something about that prior to them getting hypoxic. Because once they're getting hypoxic, we're sort of already behind the curve. So we can pick that up much sooner. In regards to cardiac arrest, there's some numbers that'll be in the PowerPoint that we talked about. Less than 10 isn't good, probably means bad CPR. Less than 10 at like 20 minutes is a bad prognosis. But again, it's a tool to use in regard with everything else, right? So you're still doing all your other stuff. You're still gonna look with ultrasound, checking for a pulse. You're doing all the other things. So just because it's bad at 20 minutes doesn't mean that you have to stop, but again, it's a tool to use, a monitoring device to use to know like, hey, this isn't looking good. We're already thinking about probably stopping because we've had asystole the whole time. We're not getting any progress. We're doing all of the appropriate things and we're still not looking good. Then again, it's another tool to use in that regard. So specifically as it relates to intubating, again, we touched on this briefly at training. So this hasn't changed any. This is, as far as I know, this is still how Hennepin is teaching residents. And I still trust the people there doing this, that this is the way to do it. So the expectation every time you intubate somebody is a video and the bougie. Every time. It's still what I do, and this is exactly what I do when I intubate patients still. So with the video, you're going to see the bougie go through the cords. If you got a second observer to see that, even better. The person who's intubating probably has a little bit higher adrenaline. The person who's assisting you probably a little bit lower in theory, but you both look at the video and say, hey, that looks like the bougie going through the cords. Right? Good. You got confirmation of two people. That's a good thing. The intubator is going to feel rings, going to feel a hard stop. If you go in the esophagus, you don't feel rings, you don't get a hard stop. So again, these are immediate. This is not like you should be able to make a correction. As soon as you go in there and you don't feel rings, you should be suspicious that you're in the wrong place. Right? I guess I can't think of a time where I've intubated somebody and I didn't feel the rings. Like it's a distinct difference between rings and just going the esophagus. And then you see, after you do that, you see the endotracheal tube go through the cords. Again, hopefully two people are seeing that on the video, confirming, yep, the tube is in the cords. Don't pull your blade out until after you see the tube go through the cords. You saw the bougie, but that's just a placeholder, right? The tube is the thing that matters. So after you see the tube go through the cords, then you pull the blade out, pull your bougie. Now you're going to look for fogging and chest rise. Again, in studies, those don't definitively determine that you're in the airway, but they are helpful in real time in coordination with everything else that we're doing, right? We want to, if we're not in the airway, we want to know it as soon as possible. So each of these things is a potential step to know that we're not in the airway and make corrections as soon as possible. The end game though is end-tidal CO2, right? You want that on the stack already. have it ready to be already plugged into your monitor, so you're getting that immediately. That's the gold standard. AHA supports that. With every intubation, we should be doing end-tidal CO2. So that's really the thing. That's our best confirmation pre-hospital. All these other things are useful, and in combination, they're good. And then this is the gold standard there. So use that tool. And again, Sean will send out the PowerPoint and another article if you want to dig into the details of it. Again, there's some debate about like in sepsis or DKA, and there's some numbers in the paper that they name from some studies. There's specific numbers, like a low end tidal correlates with low pH and high lactate. But again, they're in the discussion part of the paper with both those things. It says more studies are needed. So I don't have anything that I think we should put in writing or in a policy. Again, you can dig into it more for yourself and use that and use your critical thinking, but they're not a magic thing. I don't think it's something that we need to actually put in writing anywhere. But again, you can look at that in more detail. As far as using ultrasound, we talked about the biggest advantage, I think, again, it's a binary thing. It's a tool to use for these things. If you're looking at cardiac, we want cardiac standstill or good cardiac activity, right? Or, I mean, if you look at it enough, you'll realize like, oh, this is really poor cardiac contractility. But again, I'm not asking you to grade like 15% EF versus 30% versus 45% versus 65% EF or ejection fraction, right? Is the heart beating or not? Most time probably going to be used on cardiac arrest. Acknowledging you're going to have difficult views because you have the Lucas device on, you have defib pads on, you may not get a great view. Get it if you can, right? It's a tool to use when you can. Same thing, looking for AAA, right? It's either there or it's not, right? If you can't get it, you can't get it. But if you try and look, you have the appropriate clinical scenario, try and find it. Fast exams, sliding signs, again, it's there or it's not. If somebody has huge body habitus and you can't get good views, or maybe they actually have a pneumothorax and they have some subcutaneous air and you can't see sliding very well, or you can't see a fast exam, like if you can't get it, you can't get it. But again, the tool is there for you to use, and it's really a binary thing. I'm not asking you to look for lung sliding, like a lung point, to like grade how big of a pneumothorax. Like, do we want to know big picture? Is there a pneumothorax there or not? Do I see sliding signs? Same with B lines. Again, if you're differentiating COPD from CHF, we talked about that. Giving the wrong treatment to a patient in terms of either a nebulizer for CHF or giving nitro to somebody with COPD is not the end of the world, but ideally we're giving the right treatment to the right patient. Most of the time when those patients are the sickest, they need CPAP. So use the CPAP for those patients. If you can get a look and see like, okay, we're probably on the CHF pathway. I see tons of B lines. Even though the patient has both CHF and COPD, we're probably on the CHF pathway, right? Which speaks to this other point, like treatment comes before diagnosis, right? CPAP is a treatment for really sick patients with either COPD or CHF, as an example. The ultrasound doesn't treat them. It helps you get more information, but it's not a treatment. So don't sacrifice treatment for your diagnostics. In the same way, if you're doing a fast exam, you're already going to Hennepin for a big trauma, maybe you don't need the fast exam because you're already going there. Does it change things when you get there? If you can confirm with them, like, hey, I'm pretty sure I saw a positive fast, it's going to change what they do when you get there, when you convey that information. Conversely, if you're going to Southdale for somebody who seemed like relatively minor trauma and they have a positive fast, okay, that may change your destination. So again, it's a tool to use when you can, but I don't want the tool to be used, I don't want the diagnostic tool used in place of when the right answer is a therapeutic intervention. So again, speaks to this, right? Use it. It's another tool to use. Use it appropriately. I acknowledge that you get limited reps with this. You're not ultrasounding people every day. You're not ultrasounding every patient. I would encourage you to try to look at patients as much as you can. If you're thinking about a AAA, take a look. If you can't see it, not a huge deal, but it's fairly quick to look. If you have somebody with ascites, that would be the best way. You're probably going to see more ascites, I would guess, than you're going to see positive fast exams. But if you just look at a Morrison's pouch on somebody with ascites, and you will see what a positive fast exam looks like. So you go to a patient you know has ascites, or they tell you they have a history of ascites, just take a look. It's not going to change probably where you go. If you're going there, like say they have liver failure and ascites, and they're going to the ER because they're yellow and things are like they're jaundiced, right? You don't need to go to a trauma center for that. But if they already told you they have ascites, you can see in real time what a patient looks like that has a positive fast exam, because ascites and blood in the abdomen are going to look similar. Ascites is typically a much larger volume than a fast exam, but you will see, like, again, specifically looking at Morrison's pouch, you would see what it looks like to have fluid between the liver and the kidney. So in terms of understanding your standard views, right? So this book is around, it's in the library at both stations. There's way more detail than you need in here, but there are some chapters that clearly are related to what we do or what you're going to do. So take a look at those, understand the normal point of view for the cardiac views, understand a normal view for like doing a fast exam, right? What the rib shadows look like when you look for sliding. There's also tools within the Butterfly app. So when you're sitting around the station, need something to do or want to educate yourself more, just take the time every once in a while, take a look at the education on there and learn what the views look like so you know what you're looking for. So in terms of the hands-on, some pointers. We've talked about this. So there's my marker dot to the top of my probe. This is what I'm seeing on the screen, right? Like I'm not seeing the point of view from the ultrasound like this, right? I'm seeing the screen, and even though the screen is over here, and depending on which way it's oriented, where my marker dot is corresponds to the marker dot here, that's what I see on the screen. So my fast exam, I'm seeing a slice of this, right? When I'm actually looking, in a weird way, it's sort of like the back of your tablet, because when I look at trying to do a fast exam over here, I'm seeing like the back of the screen, right, on the tablet, which gets wonky because I'm looking at the screen over here, looking at the patient here, right? So you have to make that adjustment in your head, but understand that you're seeing the thin beam come out of the ultrasound probe and you're looking at it from the side. You're not looking at it with the same point of view as this, right? Last couple things about ultrasound. Touch the patient. When you have ultrasound gel on, your hand tends to slide. So if I'm hanging on the back of the probe here, just touching a patient, and I'm looking at the monitor over here, trying to find a cardiac view or whatever I'm looking for, I'm probably going to be sliding way around here and realize why I can't get my view, and then look back at the patient and I'm way off here, right? So anchor your hand to the patient, whatever side you're looking at, have your hand on the patient so you realize where the probe is going. When you get close to what you want to find, you have three options to try to get a better view. You can slide the probe, as in move the probe up and down, side to side. You can rotate the probe, so turning like this, or you can fan, so forward or back like this. Do one of those things at a time when you get close to what you're seeing. If you're close, I'm like, oh, that's a fast, I just need to see a little more, I want to see the liver tip, and you do a slide, rotation, and a fan down here, and you lose where you were. So once you're close, do some small adjustments, and if that works, then go from there. Like every time, so I fan back, oh, now I see a kidney, okay, I want to see a little better. I'm getting some rib shadows, okay, so now I'm going to rotate the probe to get between my rib shadows, right? So do small movements sort of one at a time. So the last part of our discussion was about AMA and refusals, right? We talked about how there's a video that Sean's going to share as well that talks about holding patients who have an opioid overdose and get Narcan, right? Generally, we still want to transport those patients. We're going to encourage them to go. We're going to encourage them multiple times to go. If somebody's completely coherent, we're not going to fight them into the ambulance on a hold for an opioid overdose. We have not been seeing like bad outcomes overall from this. There's still some liability there, but once we commit to going hands-on and holding a patient, and again, this is going to be in discussion with police, and they have the same information. You're going to see the same video that I put out for them for their roll call. So somebody who's completely coherent, we have a lot more risk fighting them into the ambulance than we do letting them be. We will encourage them to go. Again, patient care is our priority. So, hey, sir, I think it would be good for you to go to be monitored. I'm worried that the Narcan is going to wear off before whatever you took and you could overdose again. We're happy to take you. Which hospital do you want to go to? Right? So this is multiple times. Again, your documentation is going to reflect this. It's going to be on body camera if cops are there. Anybody who's there listening to the conversation, including the patient, any witnesses, anybody with their cell phone out is seeing, hey, we're happy to take you, right? But we're not going to, again, this would be like an AMA, like against medical advice. If you can get a signature, that's ideal, right? You really are encouraging them to go because you really think it would be the best thing for the patient. So, but again, we're not going to fight people into restraints or fight somebody that would require then giving them sedation, because the risk of that is much worse, right? I shared a story at training about a gal who came to the ER with some vague suicidal statements. EMS and law enforcement on scene decided that she needed to go. They restrained her. She had an injury on her wrist prior to all of this, but they grabbed her wrist, and then her reaction, since her wrists were held and her wrist was hurting from where they grabbed her wrist, she went to bite one of the providers who was holding her wrist. What's going to happen when you try to bite law enforcement or EMS? right? They're going to turn her head away and the level of force is going to escalate, right? We're trying to avoid that. So in somebody who's coherent, we really want you to go, we think you should go, but we're not fighting you. We're not going to force this thing to give you restraints, or excuse me, to give you medications or put you in restraints, because that risk is higher. So, and again, that's different than a refusal. If you think of a refusal, you show up on scene and it's a car, low speed MVC, the person is out of the car looks minimally damaged, some third party bystander called 911. So you show up and the patient's like, I don't want an ambulance, I'm not hurt, I'm fine, I'm calling AAA, whatever. Like, they have no apparent signs of injuries, they appear calm, they don't appear to be in respiratory distress, they're clearly having a conversation with somebody, so they're talking, they appear to be breathing just fine, they're standing at the side of the road waving their arm, gesturing like this, they're moving everything, they're upright, there's no starring in the windshield, the airbags didn't go off, they don't have a big cut on their head. That's a legitimate refusal, right? AMA is, you show up on a scene, maybe it's a little higher speed MVC, maybe they still don't want to go and somebody else called, but now they have a huge cut on their head, so they're holding their head, they're a little bit confused on scene, right? You want that person to go. It would be best for that person to go. So there's a difference between an AMA and a refusal. In either case, we offer to take patients to the hospital, especially in the AMA when we are really concerned about patients. Like this first one, like the minor MVC, like no reasonable person really thinks they need to go to the hospital. The person doesn't think so, you guys don't think so, and with your clinical opinion, really nobody does. It was just sort of a reaction by a bystander who said, yeah, you should, they called 911, right? Those should be pretty clear, hopefully. But the AMA is like, you're hurt, you should go. Somebody who has a concerning EKG, right? They have chest pain, a good story for ACS, and a concerning EKG, and they still don't want to go because they don't have anybody to take care of their dog, right? Like, people have competing priorities in life. That's not ours to judge, right? But again, with the AMA, your documentation would reflect, hey sir, we really think you should go to the hospital. I'm very concerned by the symptoms that you described to me. I'm concerned about your EKG. I'm concerned because your past medical history is you have heart disease, you have diabetes, right? And it's all a very diplomatic, not emotion-infused discussion, right? It's not, sir, you're an idiot if you don't go. We're not saying that. You're like, we're offering, the ambulance is here. We're happy to take you. If the patient doesn't want to go, right? We're not going to put a coherent patient, even if they're having a STEMI, if they are coherent and with it, we're not putting them on a hold. We're going to strongly encourage them to go multiple times. It's going to be in your documentation. It's going to be on body cam if first responders are there. Other witnesses are going to see it. And again, we're doing what's best for the patient. We want them to go. And we'll even say, call us back. If you change your mind, get a family member to go. Have a friend take you. Could you please call someone to take you? If you want to call us back, we will come back out and take care of you, right? And it's 2 a.m. I know that none of you want to get up at 3 a.m. when the patient changes their mind and come back when you just got back to the station and went to bed, right? So we're not saying you don't have to go over the top and say, I'm happy to wake back up at 3 a.m., right? But you still need to tell them, yes, we will come back, right? There's no judgment on this. We're not adversarial about it. You don't agree with their decision, that's fine, but we will come back and take care of the patient because it's the right thing for the patient. So if they change their mind in 5 minutes, we will come back. If they change their mind in an hour, we will come back, right? We're doing what's best for the patient, and that's a priority. So that sums up this month. We'll see you next month.